Okay, so this is Dmitry Zolimov, who's doing a lot of coronary, much more than I do. We've been working together for how many years now? 11 years, so long history. Also in my old hospital in the northern part of Germany, Bad Segeberg, we were working together. So Dmitry is a very good friend of mine, and we're going to do this case together, as you see, and he's going to do it as a first operator. So let's show the slides. So it's a left main PCI. Next slide, please. This is a male patient who's 80 years old. He's symptomatic, so having shortness of breath and actually typical angina since 6 months. Good LV functions, no regional warm wall abnormalities, and he had a positive exercise ECG. So if you go to the next slide, please. We did a coronary angiogram a few weeks ago, Dimitri?
3 weeks ago.
3 weeks ago. And you can see here he has a critical distal left main, heavily calcified, more or less small circumflex artery, and a long lesion, also calcified, extending into the mid-LAD. The first diagonal appears to be big, but it doesn't appear to have a lot of disease. Next slide, please. And he had the critical lesion in the distal right coronary artery as well, which was treated during the time of the coronary angiogram 3 weeks ago. So we're planning today to treat the left main. Next slide, please. You go to the next slide. The axis that Dimitri has already obtained is left distal radial. This is the axis you like the most, correct? 7 French is possible in the majority of males. 7 French extra backup guide with side holes. We're planning to electively rotablate actually this left main into the LED. Start with the 1.5 Gauge and may escalate to 1.7 for the left main, guided by intravascular imaging at different time points. And we're planning a provisional stenting strategy, so we'll definitely protect the circ afterwards with wire, but we're going to stent the left main into the LED. And why are we going to rotablate? And this is on the last slide. If we go to the last slide, please. The decision was based here up front, based on angiography. I mean, you're probably aware of the recent EAPCI document, consensus document, coronary calcification, where you have actually 2 possibilities depending on the setting and so on to decide on your lesion preparation strategy. So there is an algorithm which is based on angio, fluoro. In this algorithm, you may want to integrate the score that we published last year, the ROTA score, including these 4 categories. This score has been derived from 2 randomized trials we did with Access and Prepare Calc. So severity of calcification, the presence of bifurcation, lesion length, and vessel tortuosity. And you can see here the points you can give for each of these variables. And if you have a score that is more than 3, this gives you a sensitivity of almost 80% that you will need rotational atherectomy. So in his case, the score was 3.5, and this is why we based our decision-making in his case on the lesion preparation strategy on the score. Of course, you can start by trying to do imaging in his case as well, and we can discuss IVUS versus OCT as well. And then you can try to base your decision-making based on intravascular imaging, which also requires assessment of different factors. Our feeling was that probably IVUS catheter would not pass this lesion because it's very tight. And so our decision here was based on fluoro or angiography.
Any comments about the panel? Eduardo, your strategy for this case?
Thanks, Fábio. It was a very difficult case, but so interesting. I believe, first of all, we have to predilate something. Then I would interrogate the lesion before with IVUS and then rotablation. But it's not possible in some cases, because sometimes you can't cross the lesion with the IVUS. But if possible, I would interrogate before rotablation and then define the final incision.
Maybe just, I'm not a PCI expert, but just a question from relating to TAVI. Then what could a CT, if you would have a cardiac CT here or a coronary CT, could that add something on your decision for whether rotablation is relevant or maybe some other calcium modification technologies? Could that help or not?
Yeah, it's a very good question, Ole. And this has been also integrated in this document. So CT as a way to assess lesion calcification. The problem with CT, at least with the usual CTs we have in our hospitals, is that because of the blooming artifacts that calcification causes, it's difficult to quantify calcium accurately in the coronaries. So much smaller vessels, of course, compared to the valves, much smaller structures compared to the valve, and because of the blooming artifact, it's very difficult to quantify calcium in a way that helps you make a decision on how to prepare the lesion. So you will know this will be calcified. Probably you will know that you will need to do something if there are significant lesions. Then you need to prepare them by one or different tools. But you will not be able to decide how much calcium is this. And is this calcium going to dictate an atherectomy-based technique or a balloon-based technique or something else? There are newer CT generations that may be able to improve assessment of calcium, but we don't have them in our practice, and I think the majority of centers don't have these very modern CT machines yet.
Daniel?
So Mohamed, this is Daniel.
Maybe let's start.
Yes. So to save time, we will start. Maybe Dimitri.
Go ahead.
Yes.
Go ahead.
First of all, I would like to show you a couple of images. Can you see this X-ray image, angio image? It's obviously, even without imaging, it's severely calcified. Left main bifurcation and LID diagonal bifurcation. You can see calcium without any contrast. And in the next image, you can see the anatomy of the bifurcations. It's quite long, severely calcified lesion involving two bifurcations, and we hope that the ostia of the circ and of the diagonal are not involved in the stenosis. I will try to put the wire without workhorse wire, without microcatheter. It's a new generation of rotawire. It's a rotawire drive.
This is like definitely an improvement in compared to the usual rotawire we have been using for more than 30 years even now. So the rotawire drive is a new generation rotawire that Boston has developed in cooperation with Asahi, I think. And as you can see here, it behaves more or less like a workhorse wire.
Actually, it was very simple.
And we are, it's a new wire, since we will be able to use it, we are feeling much more comfortable with crossing lesions directly with the rotawire than the practice that the majority of you would do, cross with a regular workhorse wire and then exchange over micro. So this is a 1.5, Dimitri?
It's 1.5 exactly.
Yes. You already tested? No.
Not yet. I am putting the rotablator on the wire, and after that we will test the rotablator. The speed of rotation, we would like to rotate with between 150 and 160,000 per minute.
Okay.
So Mohamed, while you guys work there, would like to hear a comment from you also regarding the choice of rotational atherectomy versus shockwave technology for a case like this. Can you give us some comment on that?
Okay, great. Why not shockwave?
Is this a question for us or for the panel?
For you and then for the panel.
For us. Okay. It's a good question. So we don't have randomized data comparing rotational atherectomy with IVL. So a scientific answer you will not get. We tend to use IVL in other scenarios. So maybe not necessarily as a primary lesion preparation strategy, but as an additional or ancillary strategy. For example, cases where after rotational atherectomy you still need to work, then you can add. Cases where stents have been implanted badly and the stents are underexpanded, then you can use IVL. Or maybe in very proximal lesions that are nicely accessible with bulky balloons and where crossability is not a problem. So if you remember here, this was a very tight lesion. It's also in the left main, so you need to use IVL for a longer period of time. You could be occlusive for a longer period of time. So it would not be our favorable
But it's also
device.
a very long lesion. We could not cover the whole lesion with one IVL balloon. We will need maybe 2 or 3 of them. And in the vast majority of cases, debulking with rotational ablation is actually sufficient. I will start the rotablation. Now we will wait. I'm not sure whether you can hear it. We can hear massive decelerations in the distal lesion. It's a sign of severe calcification and of very high narrowing of the lesion.
Is this a 1.5 burr or 175?
Yes.
Yes, it is.
Yeah, it's a 1.5. And Rafa, probably you noticed that it passed the left main actually very easily. So probably if we want to modify the lesion in the left main, as we thought, we probably would need a larger burr just to be able to ablate something in the left main. But for the LED, definitely this burr is enough. It may be even a little bit too big.
Yeah.
So we will see whether we can cross after some attempts or whether we need to downsize.
Great.
Okay. Yeah. So it appears that we were able to ablate the lesion after the second run of rotational atherectomy, which is okay. I mean, some lesions are very nasty and you may need very, very, very prolonged attempts in order to cross. And in some cases, you, as mentioned, you may need to downsize if you think you started with a larger burr. But in this case, we are happy with the 1.5. And should we change that?
Yes, we
to
should.
1.75?
Yes. 1.75, please.
Okay, and we can show you how you can exchange the burr without needing to exchange the whole system. Okay. So Dimitri will probably comment on that. So it starts, of course, by disengaging the first burr, the 1.5.
It's quite easy. You have to push the button and pull it and remove the old one.
Okay.
Now you need the new one with another size.
And then the most important step is to get this really engaged.
It's a bayonet connection.
So it needs good eyes and
how often do you use two
So that's it.
burrs when you are doing a rotablator?
yes, it's also a good question. There is a scientific and a clinical answer to it. So the scientific answer, if you look at the randomized studies, then almost 85% of cases were done using one burr, and the need for a second burr was around 10 to 15%. In clinical practice, at least in the last few years, There is some research in more aggressive, for more aggressive atherectomy. So we have trials in the past that showed us that we shouldn't
Let's
exceed
check the speed again.
a birth-to-heart ratio of 0.7. But on the other hand, we are currently treating patients with a lot of calcification, calcified nodules, big vessels, left mains, and in these patients, even if you start with a small burr, as you can see here, sometimes you don't ablate enough in order to modify the lesion. And this is why I would say in Dimitri's practice, he would be using maybe like 2 burrs and
10%?
25.
No.
No?
No.
Okay. So you stick to the data, which is good.
And how often do you
Okay,
use
so this,
cutting balloon or something like this, especially for big vessels after rotablator when you are doing left main or big LADs?
yes. So not routinely, to tell you the truth, are we using cutting balloons together with rotational atherectomy, despite the fact that we have good data from Protected Combo, which is a good registry that has shown that, at least compared to a historical control group, you may obtain more lumen with a combination of rotational atherectomy and cutting balloons. But we don't do this routinely. We definitely routinely will use, in this case as well, of course, at least non-compliant balloons to check the expansion of the lesion.
And if the non-compliant
and
balloons
if not, you may be
remains
thinking of,
undilatable,
yes.
we use other devices. I will start with 1.75. I have much more resistance in the left main. It's good. It's good feeling. And actually, I don't want to go more distally with this big worm. It's enough.
I think that's a very good demonstration on how the 1.5 burr was too small for the left main, because you can see that he crossed immediately, so there was basically no resistance. And obviously you predicted that by seeing the discrepancy of sizes between the left main and the LAD. And here you can see that he had a lot more resistance, so showing the real effect of rota. And also very nice demonstration of single operator rotablation advancing into the catheter, so very fast, very skilled hands.
Thank you.
Okay, so now we're placing a regular workhorse wire beside the rota wire. So we keep the rota wire just in case we may need to use even bigger burrs. I don't think we will need them, but we keep it in place. It also gives you some support as a body wire. And then this is the regular workhorse wire, advance into the LAD. And then maybe you do imaging now, Dimitri?
We can do it. Maybe we will put additional wires in the diagonal in the circle.
Yeah, we can do this after we do imaging. Maybe.
Okay.
Yeah. So let's start with the IVUS. Rafa, please excuse the fact that we don't have the Boston IVUS here.
That's a big problem. We won't be able to see anything.
Yes, I know, but you may be able to help us get it. Okay. So our colleague Carl Crisoia, who's a cardiologist as well, is taking care of the IVUS. Bring down the. Okay. So let's see.
We are in the left main now. There is some.
It would be interesting to know whether the IVUS catheter will cross, huh?
Actually not.
It's not crossing.
In spite of rotablation.
Yes.
In spite of body wire. No, I don't want to be aggressive. We are not able to cross the lesion in spite of rotablation with the IVUS.
This is something maybe like other IVUS catheters are better. I mean, this is the one from Philips, which is bulky. So with an OCT, probably we would have crossed. I don't have.
So I think that this demonstration was arranged by Rafael, that the catheter didn't cross the lesion,
We
right?
did not rehearse this, just to be clear.
Yeah. No, we did not. We did not. So maybe like we will probably now, you'll put a wire in the circ now?
Circ and diagonal and predilate.
And then we'll predilate.
Is this a sign that you're going to need predilation with a non-compliant balloon, for example? The fact that the IVUS didn't cross the lesion?
Yeah, I mean, we would have pre-dilated with a non-compliant anyway. Like, I mean, after doing rotational atherectomy, you have to use balloons because rotational atherectomy, the aim is not to completely prepare the lesion, but only to modify it in a way that it becomes dilatable, correct? So we will need balloons anyways. But of course, now after, we wanted to see with intravascular imaging, because I mean, the aim of imaging in this case is also to decide on the size maybe of balloons and stents we're going to use. But we couldn't cross, so we'll definitely now are going to use the angiogram as a way of sizing. And then maybe before we implant stents, we try to cross again and see also how successful region preparation was at the end of it. So one wire, I think, is now in the circ.
I think just one comment. Obviously, in this case, it's not possible because the catheter doesn't cross. I think that the critical step in a complex lesion like this is the information that you get from imaging post-rota and the effect of rota, if you need to do more, if you need to cut, if you need to shock, if you need to change the wire because of wire bias to ablate other segments of the vessel, that would have been richly informative. So it's obviously a critical step. Do you agree with that, Daniel?
I think that comment is perfect. And imaging before you go with stents is, to me, it's mandatory. So you make sure that you prep the lesion properly. You can really see the plaque modification. If you don't see that, you still have a chance to modify it properly. Right? Once you have it in place, then there's no way.
Which one is the rota?
Here, this one, the fourth one.
Okay. 2.5? Okay. Mm-hmm. So this is a 2.5 NC balloon that we're going to use and see whether it's able to cross and start dilating the lesion. I mean, remember the LED is not that big distally, so angiographically it doesn't look to be bigger than 2.5. The left main is of course much bigger. And let's see how this NC balloon behaves. Eine Spritze mit Kontrastmittel. Okay, nicht, ne?
Due to massive calcification, we even don't need any contrast to ensure the wire position. Could you please aspirate? Once again.
IVUS is of course also very helpful in case you would need to do a low contrast procedure. It doesn't have to be no contrast, but you can do very low contrast procedures, IVUS guided, and also with the use of multiple wires, as you can see here, where you can appreciate the location of your lesion. 16.
It's okay. It's already open.
Okay.
Yes?
Seems to be nicely expanding, at least up till here. We'll definitely need a bigger balloon for the left main. I'm not sure it's expanding nicely here.
Not yet. Give it a little more. 24. 24. Okay.
Looks better, but this is something we have to look at.
Yep.
If the IVUS can cross. And let's do the left main.
It looks quite good.
Okay, so again, this is a 25 non-compliant. It seems to have expanded all over the way. Maybe where the diagonal arises, it looked maybe a little bit not perfectly expanded. So Want to predilate the left main
Yes.
with a bigger balloon and
Yes.
then do imaging? Yes.
At least predilate.
Yes. So
3.0, 3.5.
yeah,
Let's start with 3.0.
Okay.
3.0 balloon, please.
Are you still with us?
Yes, I was curious because the angiographic aspect of the left main lesion resembled a bit a calcified nodule. And the balloon, 2.5 balloon may be too small for you to fully appreciate whether you're expanding well or not.
Yes.
That's where I would think the IVUS would be very helpful.
Yeah, and this is why
and the
also
LED
we are
ostium, the
taking
2.5
the
still
bigger
has some
balloon
constriction
anyway.
there.
So this is an important point, Rafa, actually, in general. So if you want to use balloons to assess the success of lesion preparation, then these balloons obviously need to be big enough. So they need to be at least 1-to-1 vessel size. Otherwise, you will miss under expansion.
One important aspect when you're predilating calcified nodule regions is always to take a look at in two orthogonal projections so you can clearly confirm that the balloon is expanding properly.
Yeah, you don't see it here, but we actually have a biplane
It looks very good.
machine here, yes. And we are having two orthogonal projection all the time.
Now here.
So I think now you are seeing both projections, I guess, correct?
Yeah, we have it.
Yes. Yeah.
It looks very good. Now I'm happy with the balloon expansion.
Yes. Maybe you get a little bit into the left main.
Into the left main, of course.
So this 3.0 balloon is expanding nicely as well. 20. Okay.
Great.
Okay. So let's try this now. Let's see whether the catheter crosses. Agree?
Yeah. We can do it.
Patient is fine.
Do we want to see an angio?
We can, yes. Not really. Not sure whether we need it, but we can do
We
it.
don't need it. Yeah. The ECG is okay, blood pressure is okay, no complaints, we can work.
So we still see some under expansion of the balloon in the distal left main. Let's assume that you do imaging now and you see that there is still suboptimal preparation there. What is your plan B for continuous plaque modification? Since you now increase the lumen with balloons and a atherectomy now will be more limited in this effect.
Yes. Yeah. So there is maybe a minor under expansion of the balloon. If this was a massive under expansion, I would have taken a larger burr. I would have taken a 2.0 burr. It's not, so I would probably use something else, either a cutting balloon or maybe shockwave, but I would incline to use the cutting balloon first in this case, again, also
Can you show us
because,
the IVUS?
because the left main, I don't want to use a lot of inflation time in order to apply the shock waves. So in this case, probably you would shift to a cutting balloon. You have also, of course, the super high pressure balloons, but I don't think we will need them here. Can you cross?
I don't know.
So just for information for everyone, we're designing a trial in the US with the team at Mass General and at Columbia with Ajay and Bobby Ye, comparing cutting balloon with shockwave in patients with moderate and severe calcified lesions. So the design of the trial is physician decides whether he will use rota up front and then randomize to cutting versus shock. So you will have one arm that is cutting versus shock without rota and another arm that is going to be rota shock versus rota cut. This is 400 patients and it's powered for minimal stent area as the endpoint. So it's going to be an interesting trial.
It's diagonal branch. We can see at 3 o'clock the diagonal.
Okay, you can now see the IVUS images. I think we've noticed some cracks in the calcified plate in the LED. I think I've seen some cracks in the left main as well. So let's have a look at the images in detail. So Carl, could you Could you show us the pullback, please? Let it move slowly.
Actually, I didn't notice any calcified nodules.
Yes.
It's a circle calcification.
Yeah. There is one crack here at 7 o'clock. This is a signet ring calcification. Then here comes the circ. There are some cracks in the left main as well. I actually don't see a calcified nodule. Yeah, so some cracks, not a lot. Some cracks, not a lot, but definitely we cracked the lesion at some points. There's no calcified nodule. I was actually more or less satisfied with balloon expansion. So tell you the truth, I would proceed with stenting.
I would proceed the
here,
stent, yes. Me too.
unless you give us a very big objection.
So Mohamed, not to rush you, but just to let you know that we have a little bit more than 5 minutes for live transmission, okay?
So
Okay, so indirectly understand that we have to stent. Okay,
yeah.
okay.
So Mohamed,
So
I agree with the
stent
strategy. So I think
2.5,
you see few cracks.
2.5 stand and pot it with 3.0 balloon. I think we need quite a long stand.
I mean, this is the angiogram now. It also looks actually well prepared now, the lesion, more or less.
Can I have a look?
Yeah. So let's take it 2.5 first.
2.5, yes. 2.5,
But maybe, Carl, can you tell us the distal vessel size?
We were not distally.
We were not
of the
distal
diagonal.
enough. Okay.
We were not
We're not
distal
distal
enough.
So 2.5.
28?
28.
Yeah.
Synergy.
Synergy, yes, 28.
So we'll start with the 2.5 28 synergy in the LED. Probably we will end up just proximal to this diagonal. And then we end up by overlapping another stent into
With
the left main.
3.5.
With 3.5. Maybe we take a megatron for the left
Yeah.
main.
Yes.
Okay.
So Mohamed, obviously no objections with the strategy. I think it's fine to go with stents, but I have to say personally, and notwithstanding my obvious bias, I would definitely use a rotacut strategy based on your own trial, the prepare cow combo, because I think that
Yes.
there's still a lot, we don't see a lot of fractures. So I think it's also, for the audience, I think
Yes,
it's
some
also an option now to go with a cutting balloon or shockwave before stenting in this case.
Yes.
But stenting should be fine.
Yes. I mean, this is why the trial you mentioned is important, because we don't have a lot of data that help us in this more or less very common disease entity. And we base our decisions. We have the two trials that we did. We have some registries, but we may more or less base our decision-making process, particularly when it comes to combination of devices, based on our own feeling, experience. Correct?
Are you happy?
Yes.
Let's implant it.
Yes.
Okay. Go
Okay.
ahead. We need a 3.0 non-compliant balloon, please.
Mohamed, something important for the audience is you are leaving the proximal edge of the stent between the two bifurcations. So this is, I think, is important because the overlapping of the two stents is not going to be at the bifurcation, neither the circ, neither the diagonal.
Exactly. So we think that we ended up with this stent exactly between the two branches, and then the overlap would be between the branches and not opposite the branches, which is a very important point, as you mentioned. Yes. Question?
Just, I think 3.5 will be a little bit too big.
For the left main?
Not for the left main, but for the, I want just to put the stent.
I think we can take the stent now.
3.5.
We already pre-dilated.
We can do it.
Yeah.
3.5.
Let's decide on the length.
20.
Maybe 20 is a little bit too long.
6. Now I think 20 is great.
Okay.
3.5, 20 megatron stent, please.
So what we were discussing now is whether we should pot the stent before
we introduce the next
one, pot it maybe with a 3.0 non-compliant balloon. But I do think that probably we don't need to do this. I mean, we were happy with the pre-dilatation. So we could do this if we couldn't cross with the second stent, if it gets stuck somewhere at the stent struts. But if it crosses, then we are going to modify the proximal part of the stent anyway with the balloon of the second stent, correct?
And post-dilate the whole
segment again.
Segments, yeah.
So this is 3.520 megatron that is going now to overlap with the LED stent and go up into the left main.
Great.
It's nice, huh?
It's very nice.
Okay.
So again, just for the audience, because this stent is not yet available, I think, in Latin America. I know it's not available here in Brazil, but it's a new generation stent that is purposefully built for large proximal vessels because it has thicker and wider struts. So it only comes in sizes of 3.5 up to 5, and it overexpands well up to 6 millimeters because you have more crowns on each ring of the stent. So the stent conforms very well if overexpanded. The 3.5 overexpanded up to 6 millimeters, it's still going to cover the vessel well. And it has a lot more radial force and a lot more axial force than other stents in the market. So it's been widely used for proximal lesions, left main lesions, etc.
I'm gonna have it available very soon here in Brazil, I heard.
Yeah, we actually use it also for in a rare situation of chimney standing. Like if you do TAVI and you need a chimney stand, that's the currently in Europe I think the most used stand for this because of the additional radial force. Yeah.
Yeah, there's more connectors proximally.
You mean for chimney stenting after TAVR? If you need to protect the artery?
Yes.
Yeah.
Yes. It has a good radial force. So you know that, the development of drug-eluting stents, we used to have stents that had very high radial force. If you remember the Taxis stent and the Cypher stent, if you are old as I am now. And we used to have stents that were like stainless steel, have a very high radial force and almost no recoil. The majority of the stents we currently have are very flexible, very thin, almost all of cobalt chrome. So maybe the radial force, or there is some recoil if we implant them, for example, in a chimney situation. And the Megatron may be one of the stents that has better characteristics, less recoil.
So Mohamed, we're gonna have 2 more minutes. So can you let us know which is your plan, and for finishing the case, you're gonna place the stent, post-dilate, and what is your plan?
Yeah, we already placed the stents, actually 2 stents as mentioned. This is the post-dilatation balloon, a 3.5, non-compliant in the left main. And maybe before we leave you, we do an angiogram. And then afterwards, what we're going to do is definitely always also to post-dilate the distal stent with a smaller balloon, then do final imaging, and hopefully that's it. We're not going to do something to the circ unless we see a problem with flow, because it's a small vessel, and we don't want to intervene on it if it doesn't have flow problems. So this is how the angiogram currently looks like. So let's have a look at it before we leave you or you leave us. At least angiographically, I think the stent looks well opposed to the left main, well opposed to the distal LED, so siding seems to be okay. I don't see, at least fluoroscopic angiographic, any area of major underexpansion. The side branches are there, so this is good. So you can leave us now, have a break, or have the next session as you wish. And again, what we're going to do is we'll post-dilate the distal stent and then do final IVUS, and that's it.
So Mohamed, on behalf of all participants here, I would like to thank you very much for this beautiful demonstration again. You're being a big friend of us here, and we hope to count on you next year as well. Thank you so much for this nice demonstration.
Thank you very much, my friend, and have a nice time in Rio.